So
I'd like to
that's a
thank
great
Dr.
demo, and we're waiting
Mendoza
for your
and
video.
Mr. Ricardo
Yes,
for
you
the
can start,
invitation to
Philip.
speak here in this meeting. And I'm about to present our techniques and the results and how do we do hemodynamic sclerotherapy here in my clinic in Brazil. And I'm also presenting the results of and technique another clinic by Dr. Claudia Sattler from Belo Horizonte, Brazil. Basically, I'm trying to put this presentation really practical for you. So I'll speak more clearly than impossible. It's impossible. What vein should I treat? Uh, is there a difference if you consider ascending or descending theory? In our opinion, it does not matter. Okay. Usually, a reflux has an entrance in the GSV and an exit of the GSV, and there is a vein up and another vein down. Sometimes it goes back to the GSV later, but just a simple case for us to discuss. So if the collateral is transferring reflux to the GSV, and the reflux is not eliminated by the reflux elimination test of the distal collateral, not of the proximal one, we treat the proximal collateral. And the distal collateral that is draining blood from the GSV to varicose veins and later to a perforator, we treat it as well. Most of patients we do hemodynamic sclerotherapy are C1 patients, C2 patients, and some C3 patients also. The indications are the usual at our clinics are symptoms, and depending on the patient's complaints, some static cases also are performed. We start to do the sclerotherapy up and then go down. So if you have a collateral in the thigh and another in the leg, we first do the collateral at the thigh and then we go to the leg. And bigger veins than 0.25 centimeter, we use cotton compression and elastic stockings after the procedure to help minimize scleral formation and hematoma. The duplex scan is really important. We determine the escape points. So, for example, you have a pelvic leak, or you have blood coming from the lateral thigh, or you have another vein that is filling the reflux to the saphenous vein. And you have the pathway that is the pathway that the blood goes from this escape point, this proximal escape point, to the place where it gets back to the deep system. So this is a saphenous vein and usually a distal collateral, and then the blood goes back to the deep system through a perforator or through a smaller saphenous vein, or maybe it goes back to this bigger saphenous vein in a place more distal. And we do not treat the GSV, we just treat the collaterals. And care should be taken to avoid the sclerosing agent to get to the saphenous vein. This works really well for small saphenous vein. It's really has really good results, both clinically and sometimes even we obtain reversion of reflux of the saphenous vein. I have cases of more than 5 years of reversion of reflux that are still without reflux. So it works, and it may work even in the longer term. About the sclerosing agent options here. We use a laser to contract the collateral. We apply a shot of laser, a few shots of laser to make a contraction of the vein and to diminish the amount of dextrose that need to be injected. So we contract with laser and inject dextrose. We use liquid sclerotherapy with dextrose only and polydocanol This we use when we have a bigger veins than the smaller ones that we treat with laser and contraction. Foam sclerotherapy we use, but we do not use as a routine because foam, it's hard to avoid its backflow to the saphenous vein. So when you have a vein that is too big, like more than 60.6 centimeter, we use foam sclerotherapy, but we take great care. We compress the collateral at the entrance of the saphenous vein to avoid backflow of foam. And we keep this compression for a few minutes until the sclerosing agents is inutilized by the blood, and then we let it go. If the vein is too deep, we use echo-guided injections. And if the vein is subdermal, we use augmented reality. I'm going to show a video of that for you later. Just to imagine how the hemodynamic treatment would do in a mapping, let's say you have a collateral of the saphenous vein with reflux, a big collateral, and there's pain, and there are a lot of varicose veins and telangiectasia going off this vein. We do laser and injection at this vein. Let's say you have a few centimeters of reflux at the GSV, and then it goes to a collateral, and the GSV becomes normal again, and this collateral drains in a perforator or in the GSV or in the smaller saphenous vein. We just treat the collateral. In this case, we have reversal of reflux in several cases, in cases like this, and the clinical results are very good. Shunt 2C, we don't usually get reversion of reflux because there is a perforator in the region of the saphenous vein where the collateral is leaving. But in this case, we treat just the collateral, and we don't have flow reversion, but we have clinical improvement and aesthetical improvement. That is our main purpose when doing this treatment. So it doesn't matter if the shunt 0 remains, so there's no problem for us. Sometimes the accessory saphenous vein can be treated with this treatment. Here the reflux is usually important, and we use foam more commonly than laser and liquid sclerosing agents. But if you have a small vein, and if this accessory saphenous vein is small and drains a reflux that is not very important, not of great importance, we treat it as well with laser and dextrose with good results. And if the reflux is really important, we use foam. And again, we are talking about CU, C1, C2, and C3 patients here. In C4, C5, and C6, we perform Shiva operation in these patients. Let's say you have a pelvic leak from the pelvis, or there are a lot of places it can come. You do injection at the vein that comes at the pelvic leak, and the vein that comes from it, the GSV, and in the veins that drains the reflux out of the GSV more distally. Perforators, for small perforators, this is not used for example, for hunter perforators. We cannot use laser and dextrose. In these cases, we use foam and sometimes even ligation. But for the lateral perforators of the thigh, is it works very well, and the results are very good doing treating these perforators with hemodynamic sclerotherapy. And we treat the perforator and the collateral close to it. Just to show here a case, one session when the reflux was abolished, what did we do? There was a collateral coming here, that entered the GSV here and then coming out of here and again to the GSV. What did we do? We injected this collateral here from here to here. We injected the collateral that's coming out of the GSV at the leg. And what happened? The GSV regained upward flow during the diastole. So clinically, the patient was much better. And we didn't do a static treatment of the ankle here, but you can see that the bad appearance, the blowout of collaterals has been it's a bit better, even though we didn't treat this region yet. How is the protocol for laser and dextrose? The patients are C1 to C3, with or without reflux at the GSV. The materials we use YAG laser 1064 and dextrose sets 75%. The method, we choose the vein with duplex, as I showed you first. We mark with duplex and augmented reality. We first use laser to contract the vein, then we inject dextrose, and finally we do compression depending on the size. How is the setup of the duplex? We program it to have a high gain, low scale. We use a low wall filter. And one thing that is important, I think it's more important than the setup of the machine is the setup of our brain, because we need to talk to the patient and we need to understand where is the pain and where is the painful vein. And if there is a painful vein, even if we do not get a reflux in the duplex in this region, we usually treat it, because sometimes it's difficult to get reflux in very small collaterals. But if it's painful, we usually treat it. The energy, the spot size and pulse duration depends on the size of the vein. The bigger the vein, the bigger the energy. So spot sizes come from 3 to 9 millimeters. The jaws from 40 to 90. And the pulse duration from 15 to 50. So we use 3, 40, and 15 to those less than 0.15 centimeter collaterals. We use 6 with 50 to 60 and like 30 milliseconds for bigger veins. And those veins really big, like 0.5 centimeter or more. And with a lot of collaterals coming from it, we use 9 millimeters and 90 jaw and sometimes 50 milliseconds. The vein selection, we use the shrinking effect. I'm going to show you later in a video, don't worry. So if the vein disappears, it probably will disappear as well. But if you see the shrinking and there is something missing, you should treat that. And we use also the whitening of the skin as a mark that the treatment is working. If the skin by the telangiectasia becomes white, you probably achieved your objective. And veins bigger than telangiectasia, we always inject. In telangiectasia, sometimes we do only the laser. After the procedure, we repeat the duplex a few minutes later to check the reflux, and we repeat the duplex at the visits at 3 and 6 months, and then annual checkups just to check the results. We always do the duplex, and the duplex here in my clinic is by my side all the time. I was asked to speak a bit about CLACS. That is a technique published by Kazuo Miyake in Brazil. It's a brilliant technique. He uses laser and dextrose to eliminate telangiectasia and reticular veins. The technique is made for less than 0.15 centimeter veins. So if you have bigger veins than that, the technique is not a routine, to say, that's being published by the author of the technique. Uh, you can work most skin types with the technique, but the very dark skins are a bit difficult to do. And he uses 6 millimeter spot size, 15 millisecond pulse duration, and from 50 to 5 joules by centimeter of energy. I'm showing this because this is not our hemodynamic sclerotherapy, but I'd like to show you how we start doing this. We start doing CLEX for only aesthetic purpose. And we've seen that some patients lose, the reflux disappears after complete treatments of CLEX. So we started treating bigger veins than the veins treated by CLEX, and we start using duplex to map the veins that should be treated in this sclerotherapy. So where did the hemodynamic hybrid laser clearosclerotherapy came? We expanded the indications of CLEX, and we expanded the knowledge of CLEX, expanded the knowledge of hemodynamics used in these patients. So we have been treating veins up to more than 0.5 millimeters. The good results, the best results are in C1 patients and also C2 until 0.5 centimeter veins. Veins bigger than that, you have successful result, but sometimes if the reflux is too important, you cannot achieve the results that you want. C3 patients in normal size saphenous veins also work very well. And C3 patients now with this, I'd say, epidemic of lipedema that we are seeing in Brazil, and I think you are also seeing in Europe, the epidemics of lipedema showed us that these C3 patients of the lateral type veins work very well with the hemodynamic sclerotherapy. We treat the collaterals, we treat sometimes that you find a perforator at the lateral tie, and it works very well. And the indications about skin types are similar as CLEX. Something I'd like to discuss with you. So if you have an insufficient saphenous vein, most of the main treatments are based on the descending theory, and the main target is abolition of the saphenous vein. They want to abolish the saphenous vein more than they want to abolish the reflux. So I don't think it's right, and I think we are treating a lot of patients that do not need to be treated of their saphenous vein. Reflux is not a disease. We try to keep the saphenous vein, and we consider that the reflux may have a bit of importance in ascending theory, and also the shunts of Professor Claude Franceschi are greatly important to develop its reflux. But the lessons of lipedema and distal collaterals have shown us that sometimes you don't even have reflux at the GSV, and you can have some collaterals joining to create an area of reflux and an area of pain and some local edema and some aesthetic problem from the patients, even without shunts and without important reflux. Sometimes smaller reflux may be a problem also, and they may also evolve in cases to be worse than it was in the beginning. So the main target of this hemodynamic and cosmetic improvement of the patients. We don't need to destroy the saphenous vein. And if the reflux is abolished, it's great. But sometimes if you drain the reflux in a perforator, you have a great result, and the blood is going to the heart as well. So it doesn't matter if the blood is going to the heart through the junction of the blood is going through the heart from a perforator. The importance that the blood is going to the right place. I'd like to show you something about the prevalence of insufficiency in the saphenous vein C1 and C2 patients here. We see a lot of patients with cosmetic complaints that, during a careful examination of the GSV, have reflux. And we've seen a lot of patients that have been overtreated, in our opinion. And these future saphenous-less veins, they will have edema, recurrence, and matting. So I don't think we should start by the saphenous vein as most people are doing, mainly in these small cases. We are doing sclerotherapy with good results in these non-hard cases like C1 and C2. Let's see here. For example, Engelhorn is a Brazilian here, lives close to my business here, and he showed that C1 patients had 47%, 46% of these patients had reflux. C2, 80%. You have this, this has been corroborated by Thibault and Dong. So I think this is important. There are a lot of patients with reflux that do not have C3 or C4 cases. So we should think again before treating the saphenous veins of these patients, initial cases patients. It's possible to spare the GSV without surgery. I'll show here a few examples then. This patient from by Claudia 2022 had lateral veins draining to the GSV with reflux. After treating these lateral veins, the saphenous reflux has disappeared. Another case here, the patient had a lot of collaterals at the posterior leg, draining to the saphenous vein, and then reflux at the saphenous vein for a few centimeters before going to a perforator. And this patient, sometimes you see these patients have indication of endolaser or other destructive saphenous method. What did we do? We did hemodynamic sclerotherapy in these posterior leg veins, and the saphenous reflux has disappeared. C1 and C2 patients, you can treat the collaterals involved. For example, in this case, the patient had upper reflux and lower reflux. We treated the collaterals close to the knee and the leg, and the distal reflux has disappeared a few months later, and the aesthetic results were good. We kept the saphenous vein. It has a bit of reflux at the tight, but is not bothering the patient at all. Another case here that lateral tight collaterals and reflux at the collateral that is an anterior accessory saphenous vein that feeds these collaterals. We eliminated the accessory saphenous vein and these collaterals, and the accessory saphenous vein that was not eliminated, that was the accessory vein proximal, it even lost its reflux. So the patient is very well. The accessory vein deep portion is without reflux, and there's nothing left to treat there. This is the case of a 34-year-old woman with these collateral veins. that we showed. Another case here, a lot of collaterals at the leg and a few collaterals coming from the upper portion of the saphenous vein. We treated the collaterals, the reflux improved, did not disappear, but the patient is clinically well and we do not need to do any further treatment. The patient had a complaint about this region, some symptoms, and about these collaterals here. You can see that the region improved, the collaterals improved, the patient is well, and it doesn't matter if the patient has a bit of reflux because she has no symptoms and she's not bothered by the aesthetics of the leg. So how do we do? We use augmented reality to check the veins. We use a freezing technique that we blow cool air to diminish the pain from the laser while we inject. We use a laser. There are a lot of types of it. We use this ALMA laser, and we make a shot where at the veins we program during the duplex. And you can see here the cooling device. Now the video shows the cooling device and the shots of laser at the program places where we intended to destroy the collateral. The shrinking effect, you can see that after the laser, the collateral is not big as it was, and it's not continuous as it was. At the portions that have not disappeared, we inject dextrose. So you do the laser and you get the result that the vein is smaller. We have we can show a shrinking effect. For example, after the laser, these veins, the patient, you can see the patient is standing, she's not laying down. The veins disappear, most of them after the laser. So the vein shrinks, the reticular vein shrinks, but we usually inject them after this. The laser is aimed to burn these reticular veins as well. And at the end, at the portions we've seen that there is shrinking and they did not disappear, we inject 75% dextroses. And this is the final result of the patient after the injections and laser shots. I'd like to thank you for being here, for listening to me, and I'm here to discuss and to answer any questions that you may have.
Excellent. That's a fantastic.
Hello, my name is Marcelo Grill.
Yeah, that's fantastic.
Hello, my name is Marcelo Grill. I'm a venous vascular surgeon from São Paulo, and I'm here in clinic.
We need a second movie, just 5 minutes more, please.
Yeah, no problem. It's very enjoyable.
This is a movie showing clacks made by the clinic that started clacks.
Excellent.
Hello, my name is Marcelo Grill. I'm a venous vascular surgeon from São Paulo, and I'm here in Clínica Miyake to show you a little bit of CLACS technique. CLACS is an acronym where C represents the cryo system, L the transdermal laser, and S sclerotherapy. It's designed to use the synergy of these elements to treat small veins. With this strategy, as shown by Dr. Nasser and Dr. Almadi from Egypt, we achieved not only better results compared with polidocanal alone, but also we can rely on lower power sclerosants as dextrose 75, with the same results of detergents and without risk of anaphylaxis and skin ulcers. Before we start, in the same procedure or in a previous one, we treat all truncal reflex, bigger veins, or at least we exclude this kind of presentation. Then we perform plaques as I will show you. First, we go for the telangiectasias. As vessels with less laser target, we normally see less reaction, but it's possible to see contraction, some color difference, and some microthrombos. Here in zone, we're gonna see a really good reaction. An important tip is to avoid vein collapsing as the major target. The logic behind it is, if you are seeing a lot of reaction, okay, maybe you found the perfect energy, but usually you are over-treating, and in some cases, you can see skin damage. Here, just for illustration, we can see hair sublimation. But second, with the help of augmented reality, we go for the feeder vein. With more blood, we have more chromophorus, and we can apply more conservative parameters using less fluence, longer pulse duration, etc., not only to be safer, but also to be less painful. Here I'm performing the first pass with this setting. Fluence, 70 joules, 7 millimeter spot size, and a pulse duration of 20 milliseconds. Now I'm performing the second pass with the same parameters. After lasing, we go straight for the sclerotherapy of the feeder vein. The more you wait, the more difficult will be the punction. Another tip is to align the image of the needle with the image of the vein. With dextrose 75, vacuuming is not required. The augmented reality also allows us to follow the system healing, something desired but not always achieved. Last but not least, we inject into the telangiectasias, washing out any microthrombos and boosting the laser effect. Here, as I mentioned before, we are using dextrose 75 as the sclerosant agent. So, thank you guys for your attention and see you.
Hello, thank you. Everybody back again?
Yes,
Yeah.
that's a great video, a great demo techniques, and a great lecture by Philippe.
Thank you.
We're back to you, Erika.
Yes, I have so many questions. I mean, if the people listening have questions, they are first, of course. But I have so many questions because I never did this class, and this virtual reality. How is that generated? Is that the thermography camera, or what are you using?
No, yeah, it's not thermography camera. It's a frequency of laser that films and then plays this film at the skin.
Ah, okay. So you have to have the glasses also when you use that.
You don't have the
No.
glass. Please,
No.
you should. If you don't have this equipment, you should have the glass to see. But the equipment watches the skin and then plays like a video at the same place at the
Wow.
skin to show this. There is a bit of lag. It's really short, but you need to get used to it before when you do the injection, because it's like a millisecond to the image,
Okay.
to the equipment, and go back to the skin as a movie.
Okay. And can I ask how much this device is costing?
Last time I've checked, like 80,000 reais, like
Okay.
40,000 euros,
How much? 1,000 euros?
14,000.
14,000 euros. Okay. Wow. This is a great deal. Wonderful. So, and then you use the external laser and then the injection. Very interesting. I'm very glad you showed us all this.
Preventing some questions here, something that you probably want to know. The developers of Clax consider, I showed this video of Clax because I think it's important to discuss this in other places. But it's used mostly for static procedures, and
Yes.
Thanks.
only dextrose, because one thing that is really now it's less because the clinics in Brazil are very well prepared. But one thing that is difficult to consider is that to have an anaphylaxis to make an aesthetic procedure. So the use of dextrose in Brazil is really large scale. Most people use it, and it works really
Okay.
well. It's a bit difficult to do the injection because it's thick like honey, and
Yes.
you need to have a bit of patience to do the injection. But it works very well, and you don't have an anaphylaxis. So it's
And is it painful?
yes,
Because
it's
it's
painful.
very high concentrated.
It's a bit painful, and not too much. We do a lot, and the patients can receive it very well. And this cooling device helps to also we can use vibration as another technique. Helps to play the nerves and to distract the patient, and they don't complain too much. So
Interesting.
we do it like for 40 years in Brazil, dextrose, and it works very well. Most cases in my clinic, I use dextrose.
I have thought about using a hair fan to without heating to apply it during when I make the stereotherapy, just because this nerve changes. It's very interesting. Okay, and doesn't it make necrosis because it's so high concentrated?
Much less than foam and polidocanol. It's really a light sclerosing agent. It's no,
Okay.
we don't see necrosis. We see no problem with dextrose.
Okay.
Much less than foam. And that's why, for example, Clax, they do not use another sclerosing agents in the agent technique, and they did not use plus than 0.15 of vein size. That's what happened. It happens in 2018, I think. I had a lot of cases here that I used to do Clax, and I've seen that lots of the cases were much better than the reflux disappeared. And then I went to a meeting and I met Claudia Sattler, and she told me that she had a lot of cases like that. And we start joining our cases. We've seen that it really works, and then we start expanding the indications to bigger veins. Now we are treating a lot of cases with this.
Interesting.
I got a question from one of the attendee regarding the maximum diameter of veins that you can use Clax on. Is it 3 or 4 millimeter?
No, according to the publications of Professor Kazu, Clax itself 0.15.
1.5 millimeters.
1.5 millimeters, 0.15 centimeters.
1.5 millimeter. Oh, okay. So this is the maximum. You can't use anything bigger than that. You better use the sclerotherapy for that.
You can do, but you cannot call Clax. That's why technique we do not call it Clax, because the guys that started doing Clax, they do not accept the use for bigger veins, and we are using this in like 60.6, 0.7 veins or technique of laser and dextrose or liquid sclerotherapy.
Yeah. I got another question. Do you use a stocking after Clax session, or you don't need to use a stocking?
Yeah. Most people do not use.
Okay.
Because you are doing only really small veins. That's I Myself, I use the hobby that's 1520.
Excellent.
Uh,
Yeah.
but I've learned something. I've learned this in Italy.
Yeah.
I used to put, and in Brazil, everybody does it. I used to put a dressing after injection to avoid backflow of blood. And after I've seen some cases of skin damage by the glue of the dressing, I stopped using it, and then I
Yes.
started using the hobby instead of the compression of the dressing.
Yeah. I
Yes,
got one last
I
question here. Yeah, please.
sorry, I used to put also these little like pads and stick it to the skin. And I have
Yeah.
seen these reactions also. And this is why I wait a little bit with the people on the leg. If I see that in any place still a blood drop coming out, I put the compression, I put the pad without sticking it, and I fix it with a stocking. And I do this also in very
Yes.
large, when I make perforating veins or something, I put the stocking
Yeah.
and then I put the compresses or the pads there, and I fix it only with the stocking, because the glue of the pads can make a reaction itself, or a suction. When the stocking goes down, it can suction the skin and make this not really nice and scary and leaving scars and so on.
People have another technique
Yeah.
here. I don't use it because I kind of cut this dressings from the patient, but some people use a first tape at the skin, only the tape without pressure, and then the second tape will be glued only in the first tape, so you don't have the suction effect. It's a bit better, because
Yeah.
I don't really have like I don't have the aim to put the cotton in the exact place with a 35, for example, stocking. So I try to do this when I need to do. I use a first tape, and then the cotton, and then a second tape that will not be glued to the skin. It will be glued to the first.
Interesting.
Yeah. One of the attendees will work in a private unit, and they said he have an option to buy one machine. Would he buy Clax or buy HIFU? What do you think and why?
I, what
Those are
do
the same cost.
high full?
HIFU, high intensity focal
I know.
ultrasound.
HIFU is 10 times the cost.
Yeah, high full is 10 times the
Yeah.
cost. I would wait
Go for Clax.
first clinical trials of HIFU. That's
Okay.
something I would, but the class, I think the question is not the option to, but if you are in a private practice that you can put this cost to your patients, I think it's nice to have a laser. It's nice to have augmented reality. It's nice to have a good duplex in your room. I think, but the problem is that someone needs to pay it, and or you're gonna have the government will pay, but the governments are paying less every year. So the patients should pay. If you can charge extra for this procedure, I don't think it's a good investment to have this equipment. That's my view. In Brazil, it's really common that as the government will not cover sclerotherapy, you can invest to have the best equipment in your clinic, and you charge your patients to have the best equipment in your clinic. That's my opinion.
But I mean, we are talking about cosmetic bothering tributaries, and I think government should never pay for this. Nobody pays my hair painting, and you see I don't paint it, and government is not paying for spiders. So I think we should never charge the government for doing spiders. And if I should answer the question with HIFU and Clax, I have had a patient from Brazil this morning, by the way, and the skin is dark. And then I understand, when I try to make the spiders, why they need the augmented reality, because you don't see them. In our white, pale patients, you see the spiders so well that you don't need augmented reality to go inside them. So I always think we have to consider where we are treating before discussing these things. And my answer would always be that I would go for the HIFU as soon as it works optimally and the price goes down more than half of it, because I can treat the saphenous vein and the tributaries without any surgery. But I think this will be, I don't know if my working life will see this.
Concerning the augmented reality that you are talking about, I'm not sure. I do not agree with you in this question of skin color. For
Okay.
example, in South Brazil, and I probably is as white as everybody in Berlin, maybe whiter
Okay.
than people in Berlin now. So
Okay.
I do not agree with you, because what happens? The veins you see are not with the equipment, are not exactly the same veins you see without, and you see the connections that make you understand where did you inject the liquid.
Okay.
It's much better. We need to discuss if it's worth putting 40,000 euros in an equipment. But then I think if you can charge the patients to pay for the equipment, I think it's very good. If you cannot charge, it's madness.
I will go and visit you to be convinced.
Excellent, excellent. Here we have a question from attendee, one of the attendee. I will get the question. Yes, it's a question. It's a long question, so I will try to summarize it. I performed Shiva for 6 years and also laser Shiva, but I have too many recurrence. I have experienced many shunt type 1 and 2. I quitted the method. I did see many new vascularization at the groin where there is a junction ligation. I did see thrombophlebitis, great saphenous vein, and so on. So he mentioned a lot of complication up to the limits that he changed his performance of Chiva. So how can we get a reply from Eric and Felipe?
I may answer this, but with additional questions.
Yes.
What's the question? I'd like to be sure, for example, about the training he had obtained before start doing Shiva. I'll tell you what happened in Brazil. In the 80s, when Professor Franceschi started doing Shiva, he came to Argentina, and then people start doing Shiva here. And they have published papers and master theses and doctorates about the subject. But now that I've learned to do Shiva, I reread all those papers. In all those papers, for example, there's a paper that they did crossectomy in all the cases. And crossectomy is forbidden by the Shiva technique. Shiva technique uses crossotomy, that you leave all the collaterals draining. So I think that there is the name Shiva should be associated with a training. And I don't know if if we did a big training in Cremona, I'm not sure, maybe something about expectation. And for example, there's no perfect method. So I reoperate patients that did the endolaser in another clinics commonly here. And as I have reoperated patients of mine, there's no perfect technique. I think he should do like the math of this and see how much of these patients had problems and try to understand why. But I do not have many problems here.
Yeah. I think you touched the point of clinic very well. Erika, what do you say about this question?
I would answer furtherly that, first of all, of course, I have also a lot of recurrent varicose veins after properly performed Shiva, stripping, sorry. And so we never should claim to be completely without complications and recurrences. But the problem is, if you extract all the visible veins and leave the reflux source untouched because you didn't see it or something, it will take 6 to 10 years until these new veins appear clinically. If you leave all the veins in situ and do a tactical error, immediately the vein will be visible because it is there. It is just filled again. For example, it happens if you close the saphenofemoral junction and you have a perforating vein which you thought would be non-relevant, and suddenly the reflux comes out there. This is not a failure. This is an invitation to do the second step of the treatment after it uncovered. But it will come from the idea that one touch, we eliminate everything and the patient will have the recurrence in 5 to 10 years. We have to change the notion. Yes. We have to be humble and say, if the veins do not disappear, it is not because Shiva failed, because we failed. And this is a little bit complicated to accept. I do this for 35 years. I think I'm not so stupid to go on doing something which wouldn't work. And
and your results speak for itself. That's right. He said he got training with Professor Francesca in Italy. Can we invite the speaker to unmute his mic so maybe he can give his message verbally, if that is possible?
I have read it. I've gone to the chat. I don't know if you can unmute the mic, but the question is how many months?
Dr. Omar, but we're already 19 minutes over time.
Okay.
So,
The problem is how many months he stayed with Professor Franceschi, because visiting him 2 days is not enough. You have to be really months of training and months of learning. Because then you have to change.
Related to that compare the recurrence between Shiva and other procedures. He was not saying only Shiva having a high rate of recurrence, but he was comparing from his own practice that with Shiva was a bit higher than the other techniques. I think that was what his very
excellent. So it's very nice, very exciting. Sorry, we took a little bit of time. So we would like to have a home take-home message. From two great speakers, Professor Erica Mendoza, Professor Filippo Faccini. You can start, Erica, for your take-home message.
Thank you. The take-home message on this topic is for Felipe, because he has ideated this thing. I just want to tell you, just make sure you have evaluated the patient properly before starting. And duplex is the real base of everything. And nobody can claim to have the perfect results with everything. So the more techniques you learn, the better you will treat your patient. This is my take-home message.
Excellent. That's a great message. Felipe?
My message would be the same. I think that the most important is to correctly evaluate the patient. And I think there is a trend to over-treatment nowadays. And I think we need to think about that before we perform procedures that may not help the patient as we think. One thing that I'd like to make clear about the presentation, I don't know if it's really clear, but the approach we do here at our clinic is that we do not promise 100% results with the hemodynamic star therapy. What's the approach? The approach is we have some data here that shows that at least 80% of the cases that I indicate the procedure solve the problem. So I tell the patient, I have 80% of chances of solving your problem with this sclerotherapy. And if not, we are gonna do a procedure later. And I can even take from a message to the patient, we can do, but at least we are free of some of these veins, and we do a Shiva later if we need. So that's something important.
Yeah, thanks so much. Very, very interesting, exciting discussion. This is actually what we like about the medical non-hub, that we give the possibility and the opportunity to different opinions, and this is what the beauty of science. Agree to disagree, always the base. So again, thanks so much from my side to everyone, to our expert speakers, to the audience attendees actively participating in the discussion. Was really, really thoroughly enjoying. And before we close the meeting, I just put in the chat the link to the Medical Online Hub, where you also can subscribe to stay up to date with the upcoming events We are preparing also a very interesting topics with Dr. Eta Mendoza from her clinic, but also from other clinics, but we'll keep it as a surprise because she will travel with us in some other clinics to bring different experience and input. But stay tuned and follow our pages on LinkedIn and YouTube to watch the recording as well if you want to read back to watch one of the videos. And of course, as I said in the beginning, at the MOH platform, we offer different formats. So not only the YouTube videos or with our full webinars, but also we have one-pagers, bulletin with some studies and abstracts. So make sure to visit the website and you will see all of this kind of material there. So thank you, everyone. Much appreciated. I wish you all a nice day. If it's still morning, a nice evening. If it's night, and we see you soon.
Bye-bye.
Thanks so much.